Okay, I'll admit it. I have intentionally avoided talking about eyes on this show, and that may sound strange given that I'm an optometrist by training and I spend a significant portion of my professional life examining visual systems. When I started this project, I made a deliberate choice not to anchor it in my clinical specialty. I did not want the conversations to narrow it into eye care tips or prescription updates. I wanted it to stay focused on systems, how the body works, how health accumulates or erodes, and how everyday decisions shape long-term autonomy. But there is a topic I have postponed for too long. Vision is one of the most underestimated systems in the body. It is treated as a convenience variable. If it's blurry, you correct it. If it's clear, you ignore it. And that framing misses something very important. Vision sits at the intersection of performance and diagnosis. It determines how safely you move through the world, how confidently you drive, how accurately you interpret your environment, and how independently you age. At the same time, it offers one of the only direct windows into living neural tissue and blood vessels without invasive procedures. And most people think of eye care as prescription management. In reality, it is tissue evaluation and systemic surveillance. What finally pushed me to address this topic was a patient encounter that clarified the stakes in a way that statistics cannot. A woman in her 30s scheduled an appointment before leaving for vacation. She wanted her contact lens prescription updated and she had no complaints. Her vision felt stable. She wore her lenses responsibly and had not experienced irritation or blur. Her central acuity was excellent, and if we had stopped there, the exam would have seemed complete. But an eye exam is not a refraction. When we examined her retina, her macula appeared normal, which explained why her central acuity tested well. However, in the peripheral retina, there was a subtle distortion that had not affected her day-to-day function. That distortion represented a small retinal detachment, and it was new and it was still peripheral. Further examination revealed that the detachment was secondary to a choroidal melanoma, and subsequent systemic evaluation showed that the melanoma was metastatic breast cancer. She arrived for contact lenses and left with an oncology referral. Her central vision was intact. Her systemic health was not. And that distinction frames the entire conversation because most people equate vision with clarity. If letters are sharp and screens are readable, they assume the eyes are healthy. That assumption reduces vision to refractive error, which is measurable and correctable, but biologically narrow. Vision is not a single metric. It is a bandwidth of capabilities that include acuity, contrast sensitivity, color discrimination, peripheral field integrity, motion detection, depth perception, and processing speed. These elements interact continuously and are metabolically demanding. Most of them are not consciously evaluated in daily life. Underneath functional bandwidth lies structural integrity. The retina is neural tissue. It is highly vascular. It consumes significant energy and it reflects metabolic and circulatory stability. Structural disruption can precede functional disruption by months or even years. What patients experience is subjective vision. Clinicians evaluate structure and function. Disease frequently appears in structure before it alters subjective experience. The absence of visual symptoms does not reliably indicate the absence of pathology. Glaucoma provides a clear example of that. Early damage removes peripheral field and patterns that the brain compensates for automatically. Central acuity remains intact until later stages. So a patient may read 20/20 while losing field sensitivity that affects navigation and reaction time. Diabetes affects the retina through microvascular compromise. Microaneurysms, hemorrhages, and subtle edema can develop before central acuity changes. At the same time, diabetes influences neural processing and color discrimination. Patients with diabetes may demonstrate reduced color sensitivity, particularly in the blue-yellow spectrum, before acuity is measurably affected. Those shifts are not perceptible in ordinary daily tasks, yet they reflect retinal stress. Contrast sensitivity can decline in early diabetic retinopathy even when high contrast letter charts appear normal. A person may function adequately in bright environments while struggling in rain, dusk, or glare without recognizing the physiological basis. Hypertension alters retinal vasculature through narrowing and arteriovenous crossing changes. These findings may not alter vision acutely, but they document chronic vascular strain. The retina becomes a record of systemic pressure. Even hyperlipidemia leaves ocular traces. traces. Lipid deposition can appear in the cornea as arcus or in more severe metabolic disturbances within retinal vessels. While arcus in older patients is often benign, in younger individuals, it can reflect elevated lipid levels that warrant systemic evaluation. Retinal emboli originating from carotid or cardiac sources may first be detected through an eye exam, sometimes without immediate visual complaint. The eye is one of the few places in the body where blood vessels and neural tissue are directly observable without invasive procedures. When we look through the pupil, we see circulation in real time. We see ischemia, hemorrhage, inflammation, swelling, and mass lesions. Few other organ systems offer that level of access. This dual role of the eye deserves attention. Vision enables autonomy, and ocular examination exposes systemic stress. Functional bandwidth supports independence in ways that are rarely articulated. Contrast sensitivity influences night driving more than acuity does, and peripheral awareness affects fall risk. Depth perception informs stair navigation. Processing speed contributes to reaction time behind the wheel, and subtle color discrimination assists with medication sorting, reading displays, and interpreting environmental cues. When bandwidth narrows gradually, individuals often adjust behavior before they recognize physiological change. They avoid night driving. They choose brighter rooms. They reduce travel in poor weather. They attribute fatigue to circumstances rather than to sensory load. These adjustments are reasonable and often unconscious, yet they can conceal gradual decline. The structural layer continues to evolve beneath that behavioral adaptation. Returning to that earlier case, the patient's macula was intact. That preserved her central acuity. The pathology existed in the periphery outside the area measured by refraction. She had no distortion, no central blur, and no subjective warning. The retinal finding did not disrupt her function at the moment we discovered it, but it represented systemic disease that required urgent evaluation. The exam did not preserve the eye. It altered the trajectory of her life. That example is certainly unusual in severity, but it illustrates a broader principle. Ocular tissue can display signs of systemic pathology before those conditions produce symptoms that patients can recognize. And this is not limited to malignancy. Diabetic retinopathy is frequently detected during routine exams in patients who report stable vision. Hypertensive changes may appear in individuals who believe their blood pressure is controlled, and early glaucoma damage is often asymptomatic. Optic nerve changes may reflect neurological processes before visual complaints arise. And so the misconception that eye exams are necessarily only when the vision becomes blurry overlooks this diagnostic function. Refractive clarity is one dimension of ocular health, and it is the most visible to patients. Structural integrity, though, vascular stability, and neural function require deliberate evaluation. Vision should be regarded as infrastructure because it supports nearly every domain of daily function and because it reflects systemic condition. Infrastructure requires maintenance even when it appears to operate normally. Electrical systems are inspected before outages occur, and bridges are evaluated before they collapse. So the value of inspection lies in identifying stress before there's failure. The retina's metabolic demand makes it sensitive to systemic fluctuations. Glycemic variability influences retinal perfusion and neural processing. Chronic inflammation alters vascular behavior, and lipid abnormalities affect circulation. Sleep disorders and hypoxic states influence optic nerve health. These relationships are complex and not always symptomatic in early stages, but color vision changes in diabetes offer a concrete illustration. The neural pathways responsible for color discrimination are metabolically active and susceptible to microvascular compromise. Patients with diabetes, even without overt retinopathy, may exhibit subtle defects in color. These defects do not necessarily interfere with reading an eye chart, but they indicate physiological stress within the retinal tissue. Contrast sensitivity testing often reveals early dysfunction that acuity testing does not capture, and a patient may read 20/20 letters under ideal conditions while experiencing reduced ability to distinguish low-contrast objects in real-world settings. That difference matters when driving in rain or navigating dim stairwells. Peripheral field testing can uncover deficits that patients have unknowingly accommodated. Because the brain fills visual gaps, individuals rarely perceive early field loss directly. Formal testing provides objective measurement of a domain that subjective awareness cannot reliably assess. Hyperlipidemia illustrates another systemic connection. While many patients with elevated cholesterol experience no immediate symptoms, lipid profiles influence vascular health. The retinal vasculature visible during examination can reveal embolic events or vascular irregularities that prompt further cardiovascular evaluation. In younger patients, corneal lipid deposit may serve as a visible marker of metabolic imbalance. These examples are not intended to generate alarm, but to clarify the perspective. Ocular evaluation contributes to systemic understanding. Independence depends on functional bandwidth. Functional bandwidth depends on structural health. Structural health depends on systemic stability. When visual bandwidth narrows gradually, autonomy can narrow with it. Reduced contrast sensitivity increases fall risk. Slower processing speed affects reaction time. Peripheral deficits alter spatial awareness. These changes rarely announce themselves dramatically, but they accumulate. And preservation, therefore, is more effective than reaction. Routine examination provides two benefits simultaneously. It evaluates the performance of a sensory system essential to autonomy, and it serves as a visual extension of neural and vascular tissue that may reflect systemic change. The patient who arrived for contact lenses did not seek cancer screening. She sought clarity. Her clarity was intact. Her retina, though, revealed something else. Her case understands that clarity and health are related but not synonymous. Vision is frequently treated as a convenience variable. Glasses adjust it, contacts refine it, screens challenge it, and in reality, vision represents an integrated neural and vascular system that operates continuously and consumes metabolic resources continuously. Because the eye permits direct visualization of blood vessels and neural tissue, it provides an opportunity for early detection that few other systems offer. When individuals defer eye care because they see clearly, they equate function with structure, and that equation does not consistently hold. Maintaining visual infrastructure involves more than updating prescriptions. It involves periodic evaluation of tissue integrity, vascular health, pressure regulation, and neural stability. The goal is not to search for rare catastrophe, but to identify early stress patterns while they are still manageable. The retina is not isolated from the rest of the body, it's an extension of it. And the woman who came for contacts did not experience blur, pain, or distortion. She experienced routine life. The examination revealed pathology beyond her awareness, and her vision allowed her to function, though the examination allowed her to survive. Vision supports autonomy, and ocular examination extends beyond optics. It bridges sensory performance and systemic insight. Protecting vision, therefore, is not limited to preserving sharpness. It involves preserving bandwidth and recognizing that the eye can reflect conditions that have not yet declared themselves elsewhere. When nothing feels wrong, maintenance still matters. Vision operates quietly in the background of every decision you make. Its evaluation should not depend solely on inconvenience. That is why vision deserves deliberate protection and why ocular health deserves broader respect than it often receives. This is uncommonly remarkable. Thanks for listening.